Using specific techniques when implanting percutaneous leads may reduce the likelihood of lead migration and fracture. This segment demonstrates recommended techniques for needle insertion, lead placement, lead connections and routing, anchoring, connecting the extension connector boot, and implanting the neurostimulator. The implant techniques shown in this segment are based on consensus group recommendations that are believed to reduce lead migration and fracture. Begin the procedure by placing the patient in a prone position. Prepare the patient and locate the insertion point for the needle using fluoroscopy. Mark the entry site and administer local anesthetic around the entry site.
Insert the needle, taking special note of the following points. A shallow paramedian oblique insertion technique is recommended. Angle the needle 30 degrees to 45 degrees from midline. In the paramedian oblique placement, the site of needle entry through the skin is lateral to the spinous processes and approximately 1 to 1.5 vertebral levels below the interlaminar space through which the needle will pass. The consensus group believes that there are a number of benefits to the paramedian oblique approach.
It may facilitate lead steering. It may result in less bending of the lead. The paramedian oblique approach may reduce compressive loading compared to that of midline placement. Continue needle insertion using fluoroscopy. Confirm entry into the epidural space using the standard loss of resistance technique. A guide wire may be used to ensure a clear path for the lead into the epidural space. Slowly advance the lead past the needle tip in a midline position under live fluoroscopy and observe the lead's advancement and position. If the lead does not advance in the desired direction, steer the lead using the curvature at the tip of the lead by slowly rotating the lead within the needle.
During lead placement, it is essential to use fluoroscopy to identify the vertebral levels in the lower lumbar region. Fluoroscopy allows the use of paramedian oblique technique and enables precise placement of the needles to prevent multiple punctures.
Conduct intraoperative test screening. Once the desired stimulation is achieved, perform high-quality AP lateral fluoroscopy or postoperative X-ray of lead electrode location. Lateral lead migration is the permanent lateral movement of the lead in the epidural space away from the tissue targeted for stimulation. Lateral lead migration is believed to be less common than longitudinal lead migration, but also can change the patterns of stimulation and reduce its effectiveness. The following insertion techniques are believed by the consensus group to reduce lateral lead migration. Keep the lead close to midline as appropriate. Keep lead insertion slow and straight. Advance the lead at least 2 levels in the epidural space. Minimize injection of air into the epidural space as appropriate.
Use strain relief loops between the anchor and connector and between the connector and the neurostimulator. Place the strain relief loop close to midline but not in the midline to avoid midline scarring. Make the loop pocket the minimum required diameter of the strain relief loop. It is recommended for lead failure reduction as well as patient comfort to use a soft silicone anchor. Anchor the lead as close to midline as possible. Place the anchor tip through the fascia to reduce the kinking of the lead. Use silicone adhesive, being careful not to get adhesive on the tissue near the closure area. Place 1 milliliter of silicone adhesive in a 3 milliliter luer lock syringe and connect it to a 16 gauge plastic IV catheter. The IV catheter should be cut at a 45-degree bevel, leaving 2 centimeters remaining length. Insert the catheter between the lead and the silicone anchor. The catheter does not need to reach the end of the anchor. Fill the anchor and the lead space with silicone adhesive while slowly withdrawing the catheter and watching this adhesive level within the anchor. Suture the anchor securely with a figure 8 suture to prevent the anchor from dislodging.
Tunnel as normal and insert the lead end into the extension connector, aligning the lead contacts with the set screws in the connector and tightening the set screws carefully so as not to over-tighten and damage the connector wire. Install the protective boot.
Place the neurostimulator in the abdominal area whenever possible. Placing the neurostimulator in the buttocks area dramatically increases the tensile load on the lead anchor and may lead to a higher incidence of lead migration and breakage. Do not place the incision centered directly over the device. Create a strain relief loop by coiling the extra extension loosely around the neurostimulator. Place the neurostimulator in the pocket with the lettering facing upwards towards the incision. Anchor the neurostimulator to the fascia to prevent migration or rotation of the neurostimulator.
When using a rechargeable neurostimulator, please observe the following recommendations.
Create a strain relief loop by coiling the extra extension loosely behind the neurostimulator. Place the neurostimulator in the pocket with the white side facing up towards the incision to allow interaction with the recharger.
It is also important to implant the rechargeable neurostimulator no deeper than 1 centimeter, 0.4 inches, below the skin, as implant depth will negatively affect recharge time. Anchor the neurostimulator to the fascia to prevent migration or rotation.
In review, the following recommendations for implantation of percutaneous leads are based on biomechanical testing and consensus group recommendations and are believed to reduce lead failure. The patient should be in neutral position throughout the implant procedure, neither hyperextended nor hyperflexed. Use a shallow paramedian oblique insertion angle for easier lead steering and to minimize the potential for compression. Keep lead motion in the epidural space to a minimum. Use fluoroscopy during the implant procedure to identify the vertebral level and check the electrode location. Use a soft silicone anchor as close to midline as possible. Push the anchor tip through the fascia to reduce the kinking of the lead. Use a strain relief loop between the anchor and the connector to reduce tension on the lead. Use a strain relief loop between the connector and the neurostimulator to reduce tension on the extension. The diameter of the pocket for the strain relief loop should be the minimum diameter of the loop. Place the neurostimulator in the abdominal area whenever possible to reduce the tensile pressure on the extension and lead. Save a high-quality fluoroscopic image of the final lead position for future reference.
This presentation addresses techniques to minimize common complications in spinal cord stimulation systems. It is not intended to address all of the surgical options or complications that may arise from the use of SCS therapy. Before implanting a Medtronic spinal cord stimulation system, please review the relevant technical manuals and other educational information available through your Medtronic sales representative.